Доброго ранку, шановні учасники.
So good morning, dear participants.
Мене звати Анастасія Леухіна.
I'm Anastasia Leuchina, and I'm the author of the Not So Scary book and the editor of the Manual on Empathy and Humanity.
Здоров'я. Мені здається, що нам треба Ольгу зам'ютити.
Well, it seems to me that some participants need to mute themselves. So once again, let me repeat that I'm author of the Not So Scary book about life, death, and everything in between,
Зам'юти, будь ласка, Ольгу,
and
бо я
editor of the
говорю
Manual
дуже
Humanity and
довго,
Empathy.
це заважає.
Sirhi, please mute Olha because I can not do this. So once again, check whether you're mute because there are many of us that it's going to be uncomfortable. So I'm Anastasia Leuchina. I'm the author of the Not So Scary book about life, death, and everything in between, and editor of the Manual Humanity and Empathy in Healthcare. I hope that many of you have heard about it, and I'm the supervisor of this laboratory of empathy in healthcare. As I can see, some of you have already attended our broadcasts. We create the laboratory of healthcare to share our experience, in particular the experience in developing the courses related to humanity, empathy, and medical communications. We are developing Ukrainian experience because we had a number of broadcasts with Ukrainian speakers to see how they are implementing this in the Ukrainian context. And we have got a series of workshops with foreign speakers to exchange our experience and to see what common challenges we are faced with and to learn from each other and to also get inspired to be creating those things where you are. I would probably ask Serhi to show the slide with the manual and the QR code, just in case. If you haven't yet seen it or you don't yet know about it, so just in case, take a picture of this QR code for us to be able to all get acquainted with it. It's a rather thick yellow book, and our research has shown that the people working with this manual do not work with it just on a one-time basis when they just read and put it onto the shelf. No, you can always keep working with it because of a number of examples and ideas that could be sample as a model for you. Thank you, Serhi, and let me go over to our today's laboratory. So, taking into account the fact that during previous broadcasts, the participants asked very many questions regarding assessment because that is about soft skills, that is about communication, and that's why there are quite a number of questions regarding how progress in this could be measured and how assessment skills can be measured. So Connor has kindly agreed to have this specific broadcast focusing on the evidence base, and for this is for us to learn how to know that the communication really works and focusing on the measurement. And I'm really grateful to all of you for the questions that you have already submitted in the registration form. Connor has already taken them into account while preparing her presentation, so thanks a lot for that. And before I introduce Connor, let me say sorry for having such early morning broadcast because we made an agreement with Tatiana that we would never do things like that because of the night attacks. But Connor is in Australia, and Serhi, you could now show the map. This is just a different end of the world, and we didn't find any time that would be better within the 24 hours day and night for us to stay in the same place and in more or less comfortable conditions. So sorry again for having this morning broadcast, and I'm really sorry that some of you feel very sleepy after a difficult night. So if you need to just leave for a moment to take care of yourself, please take care of yourself, and we will share the video with you later.
And I want to introduce Connor. Connor has a PhD in health behavior science, and she is an associate professor at the University of Bond in Australia. And you have already seen how far it is. Connor has been teaching medical communication for many years. And she is, in addition to teaching responsibilities, she is also the co-head of the Bachelor Studies in Medicine at the University of Bonn. And she is also a researcher focusing on communication, teaching, and assessment. So she really specializes on this topic, and I'm very glad that she agreed to do this with us. I just want to thank Connor and also Tanya and the team who has been preparing this for you. And just say that if you have questions along during the presentation, you can put it in the chat and we will find a way to answer them when time comes, or maybe in the middle of the presentation if it fits. Okay, so just if you have a question, put it in chat and we will try to take care of it. Okay, so Connor, with that, the floor is yours. Please feel welcome.
Thank you very much. Thank you so much, Anastasia and the team, for bringing it together and making it all happen. And just to comment, I'm sorry that it's so early for you. If you got me later, I might be less able to speak clearly for you if it was later in my evening. And I end up with children interrupting me and climbing onto my lap while I try to speak to you. So that's not easy for anybody. I do just want to, I guess, begin. This is something that we do very traditionally here in Australia to acknowledge the traditional owners of the lands. I'm currently on Kumbameri country, and this is a practice that we do really routinely to acknowledge the traditional custodians of our land. And I guess I wanted to make the point to do this here, even though, as you've seen the map, it's so far from where you all are. I guess just, yeah, sharing my my hope for peace and for reconciliation for where you are. And I was sharing earlier with Tanya and Anastasia that I can't even imagine what you're all going through. And I think some of the conflict is something that some of the First Nations people of my country, unfortunately, can relate to a little bit more than I, but from a much more historical perspective. So to share, we've already heard a little about what I plan to cover, and that's, I was asked to speak about the sort of teaching, the evidence for teaching and communication and assessment. I guess just to sort of put a caveat on all of that, I will speak about evidence, and I will speak about, I'll refer to lots of published literature, but I guess it's very difficult for me to not come at this with just experience as well. And so having taught, I was previously at a previous university, I was discipline lead for health behavior science. So we managed all of the communication across a 5-year medical program. And I've done lots of research in the space. So I guess I come at it with evidence, but also just lots of lived experience in the space as well. I also published with my friends Shaq and Sarah Beege, who are part of EACH, that I'll show you the EACH website in a moment. We published in PEC, in Patient Education and Counselling, a couple of years ago now, just a little piece around what actually constitutes evidence in this space. And so I suppose just putting that little caveat on what evidence is, and that actually in this space, it's not always about, randomized control trials and high level evidence, but that lots of case studies and things like that can be really powerful, qualitative work, experiential work. And there are lots and lots of other ways of exploring what matters from a communication perspective. I'll also share with you, I guess, a little bit about me before I go too far, in the context of EACH as well. So I'm chair of PEACH, which is the Policy and Practice subcommittee of EACH. This is just from the EACH website, and it's useful for you all to have the link to that website. There are lots of resources for teaching and research, but particularly lots of teaching resources, videos and support. Also things like scales, assessment, if you're looking for things like assessment, rubrics and checklists, that you can find lots and lots of resources on that website. So each has a teaching, research and a policy and practice arm, and it's the, yes, Anastasia?
Just wanted to check if you wanted to show a slide to go with it.
Oh, I'm sorry. Thank you. There we go. I clicked
This
the
will
wrong.
help you navigate.
Thank you very much, Anastasia. So this is the EACH website, and EACH has, the 3 arms. I'm chair of the policy and practice arm, and so I really love being part of EACH. It's a really lovely community and collaborative group of people, and so I would encourage you to join, even just to have a look at the resources that are freely available on the website, and you'll find lots and lots of interesting things on there. Being part of that community has really validated for me, I guess, my role as a medical educator and as a, I hesitate to use the word, but an expert in communication skills. My good friend and colleague Marcy, who was previously president of EACH, was one of the people who encouraged me to stop apologizing for not being a clinician. So I was very much one to say, and even to students and in lots of different contexts, to say, well, I come from a health behavior science background. I'm sorry, I'm not a clinician, but I will teach these things. And she said, stop apologizing. You bring a lot. And that's very much, I think I'm supported in that. And then one of a great group of people who are not clinicians, but who bring a lot to healthcare communication, Marcy among them, and lots of members of EACH, and we can do a lot of in the space of teaching. I have just come from an interview with a new staff member who is a general practitioner here, or maybe family medicine, you might know it by, and even so we're interviewing for a teaching role, and he said, I teach communication, I take histories all the time, that's what I do. But I know that I still need to get better at it, and I also need to get better at teaching it, because teaching it is different to doing it. And so I think I can bring the teaching, I can bring the evidence for, and I guess the skills in how we teach and how we do a good job of that. So to progress. So just to reiterate, these are the sessions that you've already had. I'll try not to overlap too much with what you've already heard from Jana and Orit, but just to remind you that those videos are available to you if you want to go back to those, and to apologize to some extent that I will cover some of the things, because I guess some of the core concepts are very much core and will overlap. So I'll move into the first part, which is, I guess, the teaching part. So why we teach communication, what we should teach, and how we should go about doing that. So this is, the flower here is probably familiar to many of you as sort of the CanMEDS, and I guess it's just one of many frameworks that really reiterates, that communication is such an integral part of any healthcare professional training. Most accrediting bodies now and standards recognize communication as a fundamental aspect. It's also in sort of quality and safety standards in different countries. So I don't think I need to convince anybody of that aspect of the importance. It's also, unfortunately, at the core of many medical complaints. So there's lots of data that suggests that lots of legislation and lots of concerns that happened around healthcare can be connected back in some way to an error or a failure in communication. This is a statistic that I often use with students, just to highlight for them, and particularly, I teach students a lot of the really basic early history taking skills, so asking questions and building relationships with patients. And often I think they get a little bit bored of just asking questions and just focusing on the history taking. And this is just a reminder for them, and I think it's a really useful reminder as part of that why, that it's important to do history taking well, and it is such a fundamental component of the healthcare consultation and of information gathering. So I guess just still focusing on the why of communication. I really like these positive kind of messages, and it's more of a strength-based sort of reason to teach it. So I know it's not translated for you there, but there's a reference in the list that I've provided to a study. It's a paper that's not really a research study in itself, but Rick Street talked about looking at the theories and trying to understand why what are the pathways that actually drive this thing that we tend to know, those of us who are interested in and kind of believe in the complexity and the importance of communication in healthcare, kind of, just inherently know that communication can have an impact on health outcomes. And there are lots and lots of individual studies that demonstrate that in different ways. But I really like some of this work because it talks about the direct and the indirect pathways between communication and patient outcomes and the different ways that can function. So one of the examples is that if we have effective communication, we foster really positive relationships. We foster a sense of trust and safety with our healthcare provider. And also the understanding. And so that can be understanding from the perspective of the doctor or the healthcare provider in terms of their understanding of what the patient's concerns are. It can be understanding from the perspective of the patient in terms of knowing what the doctor means and their sort of improvement in health literacy. But it can also be feeling understood. And it's really important that a patient feels heard and understood. And if we achieve those things, which we can very much achieve through communication and the things that we see in those functions, like responding to emotions and fostering relationships, then we can really improve things like access to care and the patient's involvement in medical decision making. So if we think about patients who might be from underserved communities or feel a hesitation to seek healthcare, they might have a general practitioner who they feel comfortable with, but might be hesitant about seeing a specialist or even have trouble finding a general practitioner. But if we can build that trust, then they will actually be more inclined to see people. If a GP provides them with a referral to see a specialist, then they might be more inclined to take that advice and to go ahead and actually have that contact. If they are given a prescription for a medication and understand why they're being given it, then they'll be more likely to take it. So we start to see those pathways, and I think that's just a really nice way of really demonstrating the importance of communication and actually how it functions as I guess a mediator of some of those important health outcomes for patients. And there's just a couple of examples there as well in the second point, just about some of the studies, and those are reviews with lots and lots of examples as well of individual studies that look at some of those specific outcomes and connections. So I guess we've talked still a little bit on the why of communication, why we teach it. The other aspect is to think about the impact on doctors and healthcare providers. And we know that there is evidence of a correlation between professional identity formation, and that's something that we do try to teach explicitly, but really students, it's something that learners pick up along the way of their experience in medical school, even prior to medical school and beyond. And so a positive and what we would call, say, a mature professional identity has been associated with better communication skills as well. So I think there's something to be said there in terms of that idea. And then there's also the idea that job satisfaction and just the enjoyment of their job is actually something that's associated with for healthcare professionals who have better and higher quality communication skills. The other aspect there is the public perception of what is a good doctor. So the reference there, Grundig, in 2022 did a study where they interviewed, this was in Austria, and they interviewed 1,000 people about what they thought constituted a good doctor. And the top things were social skills, professional competence, personality, and communication. And then beyond those were things like the organization of the practice and ethical and moral behavior. But I thought it was really powerful that social skills, professional competence, personality, particularly the top, so social, personality, and communication are actually all about communication, because the way you express your personality is through the way you communicate. Your social skills are actually your communication. So even though those two actually had a higher percentage in the responses than communication itself, they were sort of saying the same thing, that actually what people see as a good doctor is so much about their communication and their interactions with others and who they are and their values. So moving in, I guess, to the what. I hope that I've kind of convinced you about the why, and there's lots and lots of evidence that we can look at in terms of the why. I'll move this to the slide that is translated for you. I know I apologize for there being lots of words on this slide, but I guess I just wanted to bring it up because this is from quite an old now. It's a review that was done published in 1995, but I think it's still really relevant and powerful. That the key thing, so this is a direct quote, and the key things that are identified there. So in general terms, communication difficulties can be described with reference to the problems of diagnosis, a lack of patient involvement, and problems with the provision of information, that the psychosocial and psychiatric problems are often missed. So the emotional, the mental health types of concerns. Physicians often interrupt patients, and that's often happening quite early in a consultation. That a lot of the time, the list of concerns that a patient goes to see a doctor with are not even heard. They're not shared by the patient or elicited by the doctor directly. And often patients feel dissatisfied with the level of information that they're provided by their physician. So for me, that's a really nice sort of quote. It's a really nice summary of the things that we should focus on in terms of what we should teach. So just to sort of highlight, pulling out from those things, that highlights for me that things like agenda setting. So when we talk about agenda setting, and I'll show you in a moment the Calgary-Cambridge model, which a lot of the language that you hear me use comes from the Calgary-Cambridge model, and you'll find that on the EACH website as well. This is a model, there are many, and it's just one of many, but essentially it's a model of the medical consultation, and it provides a framework. And it's really useful in terms of teaching to be able to show students where they're up to in that framework. And these are terms and micro skills that you will see in that Calgary-Cambridge model as well. But agenda setting is the process of making sure that a doctor or a healthcare provider understands what it is that the patient wants to achieve in a consultation and what they want to get out of it. And so that can address that concern around not eliciting all of the complaints. So only a small proportion of the patient's complaints or concerns being elicited. So if you do agenda setting well, what you're doing is hearing the main presenting complaint, but you're also exploring and screening for additional concerns. And that's something that's really important that we definitely teach students to do, is to sort of say, and what else? What else have you noticed? Or what else would you like to make sure that I make time for us to discuss today? Because what can often happen is what we call, and you'll see it in the literature, the hand on the doorknob effect, where just as a patient is about to leave or the doctor's about to open the door to say, thanks, have a great day, the patient then will say, oh, and I also wanted to talk to you about this other thing. So we really want to try and avoid that. So that agenda setting process can help with that. Responding to cues is about that idea of hearing the emotion and picking up on those things that the patient might say, but not be entirely confident to share fully. And it might be a case of a patient sort of alluding to a concern that they have. It might be an emotional one or a mental health one. And often, and I see this a lot with early learners, where they feel concerned about what they call opening a can of worms. I'm not sure how that phrase, that slang translates for you, but the idea of sort of creating more problems. They don't want to, make somebody upset or get themselves off track. They have their plan of what they need to cover with a patient, and they worry that sometimes exploring those things can send them off topic. But I guess that is really such an important thing. And again, I teach students that if that's something that the person is sharing or hinting at or alluding to, it's important to them. And it's really important that you recognize it, because if you don't, even if you think mentally, oh, I'll just park that thought and I'll come back to that later. The patient isn't hearing your thinking, and so what they're experiencing is you ignoring it. So it's really important that we help students to feel comfortable to address those things. Open questions is a really, simple and important thing just to sort of explore, and the idea of hearing stories and inviting patients to share their concerns in a narrative way. I'll talk more about some of the language that we use around that a little bit later. And then I think listening and reflecting the patient's language. So again, open questions can help facilitate that, because if I ask a patient, what happened? Can you tell me from the beginning when you first started noticing symptoms, or when you first started feeling, different? Tell me what's happened. Then you start to hear a story and you hear their language, and you can reflect that language back, and you've got something to follow up on, some more specific things. Whereas if you go straight to asking very closed questions, then you'll limit what you hear about. And then importantly, exploring the patient's ideas, concerns, and expectations, so that you are, I guess, just supporting all of those other things. So those are key things that we teach that very much align with that evidence of this is what can go wrong in communication, and the things that we can improve. So this is the Calgary-Cambridge model with an expansion which shows you some of those micro skills. So if you take away the slightly lighter colored sections in this, and I'm sorry, this one's not translated, but there may be a translated version on the each website, or I'm sure we can manage to create one for you. And this is the stronger colored bars show you the key aspects of the consultation. So initiating the consultation, gathering information, the physical examination, explanation and planning, and then closing the session. And importantly, running throughout that, you've got the structure and the building of the relationship. So those key things are what you'll see in a summarized version of the Calgary-Cambridge model. This one really importantly expands it to show what we would call the micro skills. And so those are really useful. These are, I think, a really nice toolkit in terms of if I'm teaching students, those are the things that I'm looking for. So not just whether they can initiate the consultation, but actually how they do that, the types of skills, the negotiating an agenda, using open questions, which are what we can teach explicitly and also what we can provide feedback on. So I think that gives a really nice framework. So this is, I alluded to this, that I like the idea of hearing stories, and open questions can very much sort of enable that. This is a little paper. John Lorna is a doctor who writes lots of reflection pieces. And this is one that I think just is really powerful for me, that just encouraging doctors and healthcare professionals to listen to stories. There's a movement certainly in Australia and some other Western countries talking about.
Just somebody unmuted by accident.
Thank you. So some of the movement talks about narrative medicine, and actually as a learning tool for students and even practitioners, writing stories and using narrative as a way of learning and reflecting and expressing what they're learning and the experiences that they've had. And I think this really plays to that, which is just that idea of the term inductive foraging. Again, I don't know how that translates, but that's a term that I really like. We talk about history taking, and for me, history taking is very transactional. It's a bit impersonal. I talk to students a lot about sort of cross-cultural communication, and here in Australia, our First Nations community, their history has been passed down, but through narrative. We're the longest surviving sort of culture in the world, and it's been passed down purely through narrative and through talk. And so I think it's really powerful to think about it in that way. I often say to students, be careful, because if you tell a patient you're going to take their history, that can be really confronting. But actually, if you approach it more as a way of, I'd really like to hear about your story, that's I think a much less confronting approach. Yes, Anastasia.
I think we are approaching a dangerous minefield, because right now, in the Ukrainian context, perhaps history taking in most places is the only thing that is taught in terms of working with patients. So I think like very provocative to say that history taking is outmoded in this audience. Yeah, and how do you address like some skeptical voices that this is the most critical thing, and how can you even kind of threaten it with such provocative statements?
I agree, it is very provocative, and I'm definitely not suggesting that we should stop doing the thing, as in gathering the information. I guess my thinking here is more just that if we approach it as a way of hearing about what's going on and understanding so if I think about what a patient wants to get out of a consultation with a medical professional, or a healthcare professional, it's about they want to feel understood, they want to feel safe and heard. And I think sharing stories can make them do that. And I encourage students to approach history taking. We still call it history taking, that's still what they're doing. But if the way they approach it is more about a goal of understanding what is concerning the patient, so what they are concerned about, what matters for them, and then obviously what is going on for them, and so aiming for a diagnosis as well, then that can be a really powerful patient-centered way of achieving the same thing. So I guess it's more of a dichotomy of history taking is often seen as asking a series of questions, whereas I see the goal is still the same, but if we frame it more as if my goal is to understand a patient and understand what's going on, then I might approach it in a different way. And often I just help students think about this when they do things like they say to a patient at the end, "Thank you, that's all the questions I have." Or, "I think I have everything I need," as opposed to, is there anything else you would like to share with me? Or, "I think I have a pretty good picture of what's going on for you." So it's more just the way of thinking as opposed to, changing the actual thing. I hope that helps. And thank you for prompting me to correct that. Okay, so in terms of what to teach, I guess there's lots of evidence to support it. And this was a paper by, this was again in PEC, in the Patient Education and Counselling, which is the partner journal for each, and a really nice sort of summary of the process of developing a curriculum. And I guess it's just to highlight that it's not just a case of teaching communication skills at, in sporadic moments, or thinking that if we teach communication skills in the first year of a program that's done, and that students will have those skills and be able to carry on. That very much it needs to be integrated. It needs to be part of a whole curriculum and very much spiraled throughout. Again, just this afternoon, I had a GP, general practitioner, say, "Yep, I'm a general practitioner, so I take histories all the time. That's what I do, but I'm still getting better at that." And I think that's really important, that every stage of learner, whether they are practicing or an early, pre-practice sort of learner, still have lots and lots of learning opportunity. So it very much has to continue in that way throughout a curriculum. We talk about spiraling of a curriculum, so starting with the more simple and then building to the more complex concepts based on a framework. So I think, again, you can build on complex concepts, but it's really nice and important to be able to come back to a strong foundation. And so for me, I tend to use the Calgary-Cambridge model. It doesn't matter which you use, but having that foundation is really important. And then critically, and I'll come to this in a moment, it has to be assessed. Assessment is what drives students' learning, unfortunately. There are lots of motivators, we know, but I know that one of the stronger motivators is, do I need to know this to pass? And so being able to make sure that actually the communication is given the weight that it deserves from an assessment perspective is really important as well. Sorry, just finding my mouse to move. So this is another, I guess, way of thinking about what to teach. So this is from the UK consensus statement on teaching communication skills. If you, so this is the reference is cut off a little bit there, but it's from Lorraine Noble, again, and each member and past president of each. And this and others as well, other people from each and other places have been involved in this. The idea here is that these wheels spin. So if you think about what I should cover overall throughout an entire program, is trying to get a nice mixture. So a mixture of the core being we want to teach good communication and we want to teach respect for others, but we do need to cover a bit of theory. It's really good to have a little bit of evidence there, as in to tell them the why and to demonstrate, you know, just the importance, and then to give them a chance to practice. And so if you go then to the next ring of that circle, you can say, okay, well, we can teach them about building a structure in communication. We can teach them about initiating a consultation. We could do that in the context of, and then the next ring around becomes in. So it could be in the context of different diversity, so different types of patients, uncertainty, so lots of different factors that can come in. So instead of just teaching simple, really easy and straightforward medical histories, making sure that we have a mixture of addressing sensitive issues and addressing emotions and uncertainty and those sorts of things. And then we have to think about a mixture of methods. And so that can be telephone communication, it can be in person, it can be digital, all those sorts of things. And then going to the outside as well, thinking about communicating beyond the patient. So making sure that we're thinking about interprofessional communication, that we're thinking about families and carers and teams and all those sorts of things. So this was published in 2018 and it's still incredibly relevant, and I think will remain so because it's a really nice go-to to be able to just sort of think about, do I cover all of those things? So in terms of how to teach, so there is lots of evidence. This was a Cochrane review, which is obviously, you know, it's tricky because I published this and it was a lot of work, but on one hand, you know, a Cochrane review is the top of the pyramid as far as evidence goes, but I have to sort of say that I think I take all of the findings and have a sense of interpreting them for the real world. I think the key thing, so I would say that in the context of one of the findings from the review was around the fact that maybe using students is really no different to using simulated patients for role play, for example. I think that's very context dependent. And so if you have a first year student and they've not had very much life experience or had an opportunity to really understand what it's like to be a patient with insert disease or symptoms here, then it's very hard for them to actually play that role. Whereas once you've had students who have had some clinical experience and some real world experience, then they can. So I think we do need to be a little bit careful about the interpretation. The key thing that is indisputable from this work, this systematic review, was that feedback is the key ingredient. So we know that most educational interventions make a difference. Teach students, they will learn something. But if we really want to make a difference and have an impact on learners, it's the feedback process, the tailored, specific feedback for them, and very much more of a narrative style feedback, which is really powerful. So in terms of just how we do that, what does good feedback look like? It's important that we think about feedback as being very much based on data. So what you're seeing, and this is why a lot of the learning has to be experiential. So we have to watch what students are actually doing, observe it so that we can then give them feedback. It has to be learner-centered. So beginning with how the learner felt that they went, what they were concerned about. We tend to use an approach which is agenda-led for our students. So often they will go in before they start a role play, they might have an agenda that they recognize as, I particularly want to practice a particular thing. Sometimes it will just be, I want to have a go and do everything, but finding out how they felt first is really important. Being really behaviorally descriptive is important. So by that, I mean, when I watch students take histories, do consultations, I am madly taking notes and writing down as close as possible what they are actually saying. And I then include how the patient might be reacting, and a note about, you know, whether it's a positive or whether it's something that I would suggest to change. And I might just do that with some little symbols. And what that means is that when a student then finishes their practice opportunity, I then have something really specific to go back to, and I can say, so when you said this, I noticed that the patient reacted in this particular way, or you know, you use this language here to ask this question. Are there any different ways that you think you might be able to do that? So giving them really specific feedback rather than a comment which might be more personal or based on, you know, something that's a bit more subjective, I guess. It's really important that feedback. Yes, Anastasia.
Just a quick, yeah, I just wanted to share. We are preparing such a discussion with the medical students, like Ukrainian medical students, and I was asking them, so how the learning is happening, and they say, well, we just come, we do our thing, then we get a grade, and then we have no idea why it's a good grade or bad grade, and we just don't get any feedback in terms of what we did wrong or what we need to improve. So I just thought this was like a really appropriate illustration of the issues with the feedback giving as a skill that there is in the medical education.
Yeah, thank you. And that it's interesting because I guess I come at that from two different angles. One is students always say they want more feedback. No matter how much you give them, they say they want more. But it sounds like if they're just given a grade and no feedback, then that is definitely not enough. But we often say to our facilitators, make sure you tell them that you're giving them feedback now. Because sometimes you have to flag that just so that they actually realize that this is feedback. This isn't just a conversation. This is actually feedback. But yeah, it's really powerful, and I'll talk a bit more about that in the assessment part in terms of we tend to focus on the grade, the outcome, is the student good enough to progress or not, but actually in the aspect of communication skills, it's really difficult because, you know, it's an ongoing developmental process. Everybody can always get better. Practicing clinicians can always get better and will continue to improve and learn from their patients and learn from their experience. And so to say, yes, good enough, you passed, is actually in some ways counterintuitive, because then students don't recognize necessarily, you know, where they can improve and the fact that they do need to continue to do work. And it sort of sends a message, a problematic message, I think, which is you're good enough. We have introduced a portfolio of learning for our first year students at the moment, and one of the things that they're contributing to their portfolio is feedback that they get from their clinical practice tutors. And the rubric or the grading scale that we're using is from needs improvement, developing, and capable. And that's something that we're using across all of different assessments within that portfolio. And when I briefed the facilitators on this, I said, I really don't expect many at all, if any, of the first year students to be capable for their history taking, because this is the first time they're doing it. If they're capable, then I would expect that they have a prior degree and have been practicing clinicians in a different profession for a while, because it's almost impossible otherwise for you to say that this person is capable. And so I think we need to come at it from that developmental sort of approach as well. The other point there, the next point on that slide, is around the limited amount of feedback. And I guess that plays into this developmental sort of point as well, in that feedback, often, if I let a student do a complete consultation and then I go to give feedback, there's a lot that I could give, particularly with early learners. If I said, well, right back at the beginning, if you've just done say a 10 or 12-minute consultation, and I say, okay, let's go back to, 30 seconds in, and then maybe at a minute in, there's something else. And I give them a big litany of things. They're not going to absorb all of that. They're going to feel, just overwhelmed. So it's really important that we limit how much we give on a particular occasion. And I always think of it again as that developmental approach, that today I'll focus on this thing. And this learner will have plenty of opportunities over time to get more feedback on other aspects, and to do more and have more practice. So I think that's really important from the learner perspective as well. And one of the things that we try to do there is to give students a re-rehearsal opportunity. So when they do a role play, if there's a specific thing that you might suggest that they do slightly differently, it might be the phrasing of a question, or it might be a cue that they missed, and you might suggest that they go back and reconsider or address that cue. To be able to just go back into the role play and say, would you like to go back to that moment and have a go? It's really powerful, because they then have a chance to succeed and to finish that moment, that teachable learning opportunity, feeling like they've succeeded and actually achieved something, rather than feeling like a failure and that they, have so much work to do. So that can be a really powerful sort of learning experience for them. So that's the opportunity for re-practice, but even an action plan. So I often try and make sure that every student, when they walk out of a session, that this is the thing, I want you to remember this for next time, that you need to practice this, but also bring it back next time, and we'll work on it, and we'll focus on that for you in your next opportunity. This is the same stuff, but just in a slightly different way. And again, I'm looking at the translation there, it doesn't have the same acronym, but it's just easy. So if you do speak English, and remember that English, FIT and ABLE is a nice acronym as a way of thinking about the way to present that feedback. So it's frequent, so giving them plenty of opportunities and providing feedback regularly. It's interactive, so it's a discussion. How do you think you went? And then, okay, I'll give you some feedback about my thoughts, and it might be the simulated patient or the role player's thoughts as well. It has to be timely, so you don't want to watch something and then give them feedback a week later. In the moment feedback is most powerful. And then ABLE, so appropriate for the learner level, focusing on where they're at. Behaviorally specific, like I said earlier, labeled, so that they know that they're receiving feedback, and empathic, so that they know that you understand that they're an early learner and that they've got scope to improve, so that you're obviously not being kind of harsh, I guess. So that was, I guess, the why, the what, and the how very, very quickly. Anastasia, did you want to ask any further questions before I jump into the assessment part?
No, I think we have about 40 minutes left. So this is about half. Okay. And you are doing great. And I think most of the questions that we had were on the nitty-gritty of assessment. So I will just skip the second part.
Okay, sure. That's fine. So to jump into assessment, and I've deliberately left time here for discussion and for questions, because I think there's lots of sort of context specific questions that people seemed to have. Sorry, there we go. So as I said earlier, I know that students are driven by assessment. As much as we don't like that fact, or don't really like to admit it, it's very much the case. So we really need to focus on authentic assessment of communication, but it is very difficult to achieve. So what, and I'll come back to the definition, but the idea is based on the work that I did as part of the consensus statement, which I'll show you in a moment, with, again, a team of people from each. We worked on trying to work out what is the goal, what's the consensus that we have around assessing communication skills for health professional students. And what we really needed to start with was, well, what are the skills that we want to assess? What do we want to achieve by the end? So we might look at history taking in first year and, building on that in second year. We might look at specific things like, breaking bad news and those sorts of things. But those are very specific tasks of communication. If we think about what we really want to achieve by the time a person graduates and becomes a healthcare provider, what we want them to be is a skilled communicator. And we agree that that's somebody who is flexible in their communication. They might have a framework and a sort of a structure for what they want to achieve in a consultation. But as I learned from Jonathan Silverman, he tells me that it wasn't his quote, but he said to me that structure sets you free. So having a structure, we tend to start with a framework for students, but then the idea is that they have that as a safety net so that they can actually follow the cues that the patient provides, that they can adjust their approach for different patient needs, but they can always come back to that safety net of structure. The other part of skilled communication is thinking about, well, what's this particular patient? So I might have a patient who has a learning disability. We might have a different level of health literacy. We might have, a hearing impairment or a vision impairment and those sorts of things. So to think about how we can tailor our approach for all of those sorts of things and cross-cultural and that kind of thing. So skilled communication is complex, which is why I really don't like the term soft skills. That's something that we tend to, phase out because I think it's very hard. It's a very challenging skill to get this right. So this is the consensus statement that I mentioned. So what we did in this process was we had all of these authors that you can see listed there were involved. We got together. So these are people who are part of the assessment subcommittee of, or the assessment working group of TEACH. Yes.
I just want to advertise that at least 2 of them will be our speakers in the fall. So
there you go. So it's like I said to you, we're each is a great community. So yeah, fantastic group of people, and we tried to be, we're very global. So there's people from all around the world on that list. And what we did was we got together, over many times, and to work out what we saw as the key focus and the key, priorities for assessment of health communication in the modern time. So there have been previous consensus statements, but they were more, I guess they're sort of a little outdated around the particular focus. So we really wanted to look at what in the contemporary time are the challenges for this topic. We did like an informal kind of Delphi process. So we had lots of discussions, which we sort of used as in a sense, like a focus group type thing. From there came up with some themes, and then ran with this group of experts an informal Delphis to identify our top priorities. And that's what drove the priorities that are in that consensus statement. So like I said, this was our definition of the skilled communicator. So somebody who adeptly navigates communication tasks, employs a variety of communication skills during consultations and all professional interactions. So that meaning not just medical professional and patient, but also interprofessional and team communication with families, tailoring interactions to suit each person's unique perspective, needs and wishes. So we made it concise, but there's a lot in there. As you can see, if that's what we're trying to achieve, there's actually a lot of practice and a lot of skills that students need to, in order to achieve that. So stepping away from that consensus statement just for a moment, this is an example. This comes from the Bachman paper that I mentioned earlier with the cycle of curriculum development. This is just a nice summary of the focus of assessment of communication skills. So it's relatively easy to assess knowledge, but knowledge doesn't necessarily translate in the space of communication skills. It doesn't necessarily translate to behavior. So you can do some written exams and key feature tests. SJT is the situational judgment test, and that can get to things like sort of values and that type of thing. Skill spotting can be useful. So it's a process whereby, you could have an observation demonstration or a video of communication and have students identify particular skills, strengths and weaknesses that they see in an interaction. So those can be good to determine whether students are understanding, I guess, what good communication should look like, but it doesn't necessarily tell us that they will practice that, or that they can or are practicing that. So to assess the skills themselves, we tend to use things like OSCE, so objective, structured clinical examinations. They can be recorded interactions. Mini CX or mini clinical examinations. Docs are direct observation of clinical skills, or patient evaluation. So those are all very widely used. And then you can do some assessment of sort of attitudes through things like reflections and interviews, which can also get to some of the behaviors and attitudes. My sense is that really having a mixture of all of these is probably ideal. In many ways, I'm less concerned about the knowledge, in that if they can do it and show it, I don't mind so much whether they can tell me what the skill is called. But it can be a useful way to spiral if you have the opportunity to do some early sort of knowledge assessment. But increasing, is that a question, Anastasia?
Yeah, I think
Yeah.
someone. Ольга Муравіцька, можна вас попросити м'ютитися, бо
Olga
ви
Morawiecka, I would ask you to mute because you keep interrupting our flow. Thanks a lot.
Also, to give you a short break for water, we had a question. I just want to slow you down here a little bit. We had a question in the forum asking specifically how to measure attitudes, and I wonder if this is a good place for you to really expand a little bit on that.
Yeah, sure. So it is tricky because there are some so multiple mini interviews is probably a nice example, or situational judgment testing is kind of they're ways of getting at attitudes and values. So those are things like where you ask students questions, maybe give them a scenario and ask them how they would respond. And so those can be helpful. We tend to use those, at least in Australia, more in the context of selection into programs as opposed to during programs themselves. So I guess the idea being that we have students enter the programs who already have the right kind of attitude towards healthcare and towards communication. It's not always, it's not perfect, but that then means that our assessments within our programs tend to focus more on the skills rather than the attitudes. Having said that, those scenario type things I think are quite well used. I've used things like hypothetical scenarios based on what the theory of planned behavior. So it could be you give a scenario and you ask how the person would respond in a sort of multiple choice type way, so they can select their approach. And those types of things can get at attitudes towards communication and the way they would approach a patient without necessarily having to actually measure that. And they have some level of prediction towards actual behavior, but then again, not perfect. So increasingly assessment, again, I'm not sure where sort of medical education in the Ukraine is up to, but certainly in many European and sort of UK and America, moving towards programmatic assessment. So rather than just looking at big high stakes assessments and sort of a small number of data points where we would have a dichotomy of formative and summative. So we would say these ones are for feedback or for learning, these ones are for decision making. We're moving towards a situation where we have a program of assessment where we have lots and lots of data points, and it's more like a scale of stakes. So rather than being formative, summative, or low stakes, high stakes, it's actually, some of them might just have different weightings, different importance. And so gathering data from across a suite of different types of assessment and different models, I think is much better. It strengthens all of this. As we know, learners You know, some learners are really good at written type tests. Some get really nervous in those situations. Some get incredibly nervous with the performance type examinations and tests. And so enabling learners to be able to demonstrate their skills in different contexts can be really helpful as well. So this is something that is, you know, might be familiar to a lot of you, but just, I guess, the idea of constructive alignment. So in assessment, we tend to think of you know, any curriculum has to be constructively aligned. So our learning objectives at the top, need to then be supported by teaching and learning opportunities, and then be assessed. And this is best practice constructive alignment. Where we go wrong is where we sometimes have some teaching and some assessment without the learning objectives being identified for the students. And so that missing that part can be tricky because the students don't realize the importance. So that's where it's really important that we specify communication as a fundamental learning outcome. And when now most, certainly medical schools in Australia, our Australian Medical Council dictates our standards, we have multiple communication standards within that. So that's really clear. Obviously, having those standards and those learning objectives, we then need to make sure that we actually support them with learning and with assessment. And so this is just an example of if we don't do that, then we won't get anywhere. We won't ever know if we've met those standards or not. Sometimes we do some teaching and we don't do anything with it. And this is really risky, I think, where we just throw something into a curriculum because somebody's passionate about it, and somebody thinks it's important, but the students won't think it's important unless it's got the other ends of that in terms of the learning objectives and the assessment as well. And then obviously there's a risk if we don't do the teaching. So we need to support all three. So this is I guess just some thoughts around that in the context of communication skills explicitly. I had a PhD student who did some work where we looked at objectively what students do in the classroom and what they do in clinical placement in their actual practice, and then what we assess. And I think this is one of the things that is probably the biggest sort of downfalls or weaknesses, challenges associated with assessing communication skills. So we tend to be pretty good at identifying that it's important, and so we'll have a learning objective or multiple learning objectives about it. We certainly here in Australia do quite a bit of classroom teaching. So it's structured, it's supervised, we give feedback on it. It tends to be based on the frameworks. Sometimes it's limited to just parts of a consultation. So students, here at Bond, where I am now, we tend to let students do a full history consultation. Previously, I was at a university where we had much larger groups, and so the ratio was a bit different, and we had to have students just do snippets. And so sometimes an individual wouldn't get to do a full consultation, which would mean that they might not have practiced all of the components. But in general, they would practice very structured and receive feedback. And then when students go on placement in clinical settings, they're often not observed or supervised. They would have an opportunity to interact with patients. And we recorded multiple students interacting with patients in clinical placement. And a lot of them took quite a long time. They had lovely conversations with patients that were wide-ranging, but often very unstructured. They were quite comprehensive around the gathering of information, but there was no feedback on how they did that because there was no clinician there to watch them. And that's pretty common because there's often we just don't have that level of supervision in clinical settings, and often an opportunity to go and talk to a patient is what students get. Go and talk to some patients while I'm busy, says the clinician, doing something else. So that's great that they have those opportunities, but without the structured and tailored feedback, what ends up happening is the student often will report back a case to a supervisor, to a clinician, and then the feedback is purely on the information that they gathered rather than how they actually gathered that information, the way they interacted or the questions that they asked. So you can already see that there's a little bit of a mismatch, a dichotomy. So we tend to, we have a focus on the interpersonal, and then we focus on the content. And then when we get into assessment, we try to bring it together. So a lot of, I'm going to say the majority of medical schools use OSCE, so objective structured clinical examinations, and they are time limited. They're focused on quite specific skills. So there's a scenario that's very focused, and it tends to include some component of the communication as well as the clinical stuff. So whether a student can actually solve a clinical problem, reach appropriate diagnostic, identify differential diagnoses and come up with an appropriate diagnosis. And so we tend to give them a really short time as well. The logistics of OSCEs are such that they're very resource intensive, and students are often given maybe 8 minutes to do quite a lot. So it tends to perpetuate bad habits, because what can happen is students go, but I need to make sure that I demonstrate my knowledge, and I've only got 8 minutes, so I don't have time to be empathetic, and I don't have time to build a relationship. And often they can still pass because they've managed to, do all of those other things. So that's, I guess, one of the downfalls. And so we see this sort of mismatch between those different aspects of communication. So coming back to the consensus statement, these are the points that we really sort of, highlighted as our practice points. So as I mentioned, the goal is about developing skilled communicators. I've mentioned that programmatic assessment, I think, offers great potential. So the idea that rather than just relying on, say, OSCE, that actually relying a little bit on other things as well, where we might see some more authentic interactions with patients, and having a mixture where we can observe students interacting in more authentic settings, and gathering a broader data set about students. That can be really a powerful way to assess lots of things, actually, and it's ideal for communication skills. Narrative feedback is the most powerful, and so making sure that we're not just giving a grade, sorry, making sure that we're not just giving a grade, but that we are providing the narrative feedback with some actions for students to improve on. And then systems of assessment considering diversity. So I guess coming back to the idea of programmatic assessment, making sure that we're not just assuming that every learner can perform in the same sort of context. And so considering learner diversity as well as patient diversity, thinking about gathering data around students interacting with patients from different contexts. So it might be different cultural backgrounds, it might be in different healthcare settings, so not just hospital, but also primary care, a whole range, also interprofessional communication. But then also thinking about the diversity from the perspective of gender diversity, cultural diversity, learning disabilities and differences and those types of things. So we need to be able to tailor approaches to those as well, and some opportunities for students to be observed in those types of interactions are powerful. Yes, Anastasia.
There is a question in the chat from Irina. And maybe Helena, you could translate it for Connor really quickly.
Yes. So thank you for the information provided. Could you show an example of summative assessment of communication skills while having a practical session? How do you substantiate the difference of grade from 3 to 5? That is the question.
Yeah, great question. Oh, sorry, my computer just went strange. So that's a really good question. That sort of rubric style of having to make decisions is very challenging. And it is where it becomes a little bit subjective. So we talk about empathy, and I know there were some questions around how we assess empathy, and it's very much a subjective sort of thing in many cases. We tend to look at the global versus the checklist. So you can look at a checklist and say, did the student do these things? And that could be ask an appropriate mix of open and closed questions? Did they introduce themselves? Did they respond to patient cues? And so you can be quite explicit about whether they are doing those things. But then another really powerful thing is to look more at a global thing, a global rating of and you can do this actually using patient perspective, and that can be expert patients, simulated patients, or real patients, where they actually can rate how they felt. Did they feel like they were heard, like their story was heard, those types of things. And so, you know, another option is then to have a little bit of both and to sort of triangulate those two types of data. There tends to be reasonable sort of alignment between assessors when we have a grading. So if you have to say this person gave a rating of 3 and this person gave a 5. But also that's partly why in an OSCE you have multiple stations, because we know that actually what we call hawks and doves. So there are hawkish, very hard markers, and there are dovish, very easy, friendly markers. And the hope is that students get a mixture of those and that it evens out across multiple stations. But again, the more data points, the better from that perspective. I'll carry on. I hope I might be able to come back to that a little bit more. It's a great question, because it's that idea of pardon me, that idea of decision making based on an observation of communication is quite difficult. And often we do tend to refer to the sort of gut feeling, as in the Gestalt sense of was that good or was that not good? And sometimes that can be really powerful, but the checklist or the list of items or micro skills can help provide some guidance as to why it was maybe good or not so good.
And by the way,
so following on, sorry?
Yeah, just wanted to say that you just answered another question that came from the registration form on how to use checklists. So thank you for that. And Irina is also thankful for your answer.
Oh, good. Then it's sometimes these questions are tricky because there's not just a simple answer. But one thing I'll say is I'm very happy to be contacted, and if people, you know, have further specific questions that I don't answer here, or can't find resources on the EACH website, people feel free to contact and I can share some resources as well. So moving on, the next sort of practice point in our consensus statement was around workplace-based assessment. So it's really helpful to look at the performance and the action. So we tend to think of OSCEs as they came around in the 70s. They've been around for a long time, but there's a recognition that they're not authentic in many ways. Students tend to game the system a little bit in terms of second guessing what they want us to hear. What, you know, they know that we are asking questions and that we're looking for particular things, and so they're often more focused and fixated on that than what they would actually say to a patient. So by observing them interact with patients in a more authentic setting, that can be really powerful as well. So again, coming back to the programmatic, a mixture of these two can be really great. When I say in that point that it enables assessment as performance and action levels, that just refers to the diagram on the side there, which is, again, you might be familiar with that Miller's pyramid of teaching and assessment, where we really want to get to the performance of actually showing how, but doing. And ideally, ultimately, by the time we have people graduating, we want them to just be good communicators. So the idea that it's a performance is still, I'm doing this consciously and I'm on show. We really want them to progress into just doing, just naturally, and being a good communicator as part of their professional identity. So that's an extension of Miller's pyramid that was added to by the Kruse partners, looking at they have done a lot of work around professional identity formation. So the next point is around considering the assessors. So I've alluded to this as well in terms of being able to bring in, often we we assume that the experts, the clinicians, are the ones who should assess all the time, but there is some value in including the patient or peer perception as well. Peer assessment of students can be really powerful and actually a really great learning tool for the peer giving the feedback in terms of forcing them to provide some critique, and it's a really positive thing to do as part of learning. And patient feedback can be incredibly powerful. So it can stand alone. It can be a way of adding to. So previously what I've done is had essentially the content component marked by an expert, an assessor, clinician, and they looked at the communication as well in terms of those specific sort of micro skills of communication. But we asked the simulated patient just to provide a general feeling of, did they feel like they were able to share their story? And that's really powerful. Sometimes simulated patients, when they're asked to mark a full sort of rubric, they tend to just be kind and not differentiate too much between students. But when you give them that chance to just on a sliding scale say, I felt like, you know, this person built rapport with me, I felt a connection, I would, and that's the other question that can work is, would you come back to see this doctor again, or would you recommend this doctor to a family member? So those are really simple but powerful measures as well. The next point is around interprofessional assessment of communication and assessment of that, and that's very challenging. It's challenging to do the teaching of it, and then the assessment is a whole nother factor. And this was probably one of the more challenging sections of our consensus statement to write, in the sense that there isn't a clear consensus on how to do this. All of the other areas, we felt like there's a really clear direction that we're moving in, and that the literature is moving in, and just the medical education sort of field in general. But actually interprofessional education is tricky. The one thing, and I think I've certainly been trying to put this in practice more recently, is that if we're assessing teams, they should be authentic teams, rather than throwing people together in kind of like a pretend thing and going, now perform as a team would. So if you have students in a group doing something authentically as part of a course, then being able to assess how they actually interact is potentially one of the more powerful ways, rather than creating a simulation where you put people who have never met before and have to work with complete strangers. So it's a mix. And there's certainly some opportunity for simulation in that space, but definitely a challenging one. And then I guess the final couple of points were around technology. So we know that technology will and is changing assessment all the time. So and as we were writing this, we knew that AI was changing things to an extent that by the time we'd written a sentence, it was already outdated. You know, the world is changing so rapidly. But we know, I'm sorry, my colleagues outside are being very noisy. We know that this world is changing, and therefore assessment will change. We were able during COVID to both teach and assess online, which in 10 years ago would just have been unheard of, and we were able to do that quite successfully. So it's opening up opportunities for the way we conduct assessment. It's allowing us to potentially do some more things like observation of assessments, recording, those types of things, and potentially down the track using AI to do some marking, which might be a more objective way of marking as well. I haven't gone there yet, but just it's also something to think about. And then the other aspect of it, of course, is the impact of technology on the communication, and therefore we must make sure that when we're assessing the different forms of communication. And so telehealth, again through COVID, became much more prevalent, but of course it's continued. You saw the map of Australia, we're big and spread out, and so we were using telehealth here long before COVID, and continue to do so. And so improving the way we actually teach for that, and making sure that students have the skills that are specific to that kind of communication is another factor. So I've talked a bit about OSCEs. I want to make sure that we sort of have time for final questions if there are further discussion points. So I won't spend too long on this. But I guess, yeah, just to highlight that they're great, but they are very resource intensive. We require a lot of data for these to be really valid and reliable, so they have their place. And again, there's the AAMI guide in the reference list is a really nice, quite practical guide for if you haven't, conducted OSCEs and are looking at doing so. That can be really helpful. And it's important that in OSCEs we balance the medical knowledge and the process skills. So that's important in the sense of the way a station is written and the way a rubric for marking is established. So making sure that learners understand that actually the communication aspect is an important aspect and should be given the attention that it deserves. In order to do that, it means that you really need to train your assessors as well, because often we get assessors, expert clinicians to assess OSCEs. And they tend to focus a little bit more on the clinical, on did this student get this right? Did they, get to the right diagnosis? Did they go through the right clinical reasoning process? And that's important. It's incredibly important. But I think OSCEs have an amazing place. They have such a great opportunity to really look at both the process and the content. And so in order for that to work well, it's about well-written stations, well-trained assessors, and marking rubrics that really support that and I guess emphasize the weighting of that component. I mentioned workplace-based assessments. So these are authentic in that they are in a clinical setting, observation being by a marking clinician. I say validity increases when observed because sometimes you can have a workplace-based assessment, which is more like I mentioned before, where a student might interact with a patient and come back and report back to a clinician. That's really problematic because, of course, they might be able to comment on the information gathered, but not the way it was gathered. And so that's an important thing to make sure that we're actually observing students. It's resource intensive though, and it does require some training and empowerment of assessors. I've put empowerment there because often clinicians who are supervising students in clinical settings don't feel particularly comfortable or empowered to fail a student, to say that they're not quite good enough. And this is something that we really need to encourage clinicians to do particularly. I think clinicians who are a little bit removed from the medical school or the university feel like, oh, I don't want to cause trouble and fail a student. But the message that we often have to give people is this person might be your colleague next year or the year after. You have an obligation to make sure that they're safe as a colleague, as a, person treating members of the community. And so sometimes the opportunity to remediate a learner through not meeting a competency or not, passing an assessment is actually the most powerful feedback that you can give them. So even though I might criticize the giving a grade only, sometimes that in itself is feedback to say, you're not quite there yet, but let's work on how we can help you get there. So to bring it all together, just to kind of recap on, I guess, the key points for the teaching component. I think communication skills teaching should be so valued, but it has to be integrated in a whole curriculum. If it's not, and if it's just a standalone, students won't value it. They'll see it as a soft skill. And so that's really important that we have to integrate. It has to be based on a framework, and that provides them with that, freedom in terms of being able to feel confident to deviate and then come back to that framework. And it has to be reinforced in a spiral with lots of feedback throughout. Communication skills assessment should be valued. So when I say that, I mean, if we're doing an OSCE station, we can't just say, oh, give communication one little tiny line and one little tiny proportion of the marks. It actually has to be numerically valued as well. It has to be integrated and aligned with the learning objectives and with the learning opportunities. It has to be, again, based on a framework. Ideally, it should be programmatic, so it's lots of data points to help make decisions about students, rather than having to make a decision based on a single point in time. And ideally, it should be authentic. So that's a really long list of references, which if you can get access, and I think I said to Anastasia and Tanya, I'm happy for that to be shared. I can provide a sort of a Word document if that's easier for you to access that. And the slides will be shared. So I'm really grateful. I saw the number of you. It's a little bit odd. I feel like I've been talking to just Anastasia, really, because I've been able to see your face, which is lovely. But when I see the number of participants, it's really lovely to see how many of you have gotten up and joined. And I hope I've been able to, share some useful insights for you.
Connor, while I ask you the last question, you can also change the view, and then you see the faces actually. And
okay.
Do that and people were really kind and turned on their cameras for us today. So I think we are running out of time, and I want to ask one question about empathy, because it came in the chat, and there were a variety of different ways people are asking, how can we assess empathy? Should we assess it at the start, like before people join the programs? Is it possible to assess it, and how can we assess the development of empathy throughout learning? So maybe we end with empathy and assessment of empathy.
Excellent. This is a topic very close to my heart, so I'm very happy to do that. So I mean, it's a tricky one in that it can be objective. Having said that, I think it's a little bit of everything. So empathy as a value, as something that is inherently part of a characteristic for individuals, I think we can assess that at the start, and we can try to have learners in our programs who are more inclined to be empathetic. Having said that, it's not an exact science in order to do that. So we should try to do that, but then we can always continue to improve it. Again, importantly, empathy is a feeling. And so I can't assess whether you feel bad for somebody, but I can assess the way you demonstrate that. And in many ways, it doesn't matter if you don't have the feeling, as long as it is demonstrated in an authentic way that the patient feels it. So one part is to ask the patient perspective. Did they feel that the doctor, the healthcare provider, was empathetic? Did they feel like they were heard and understood? And I think that's very powerful. But then there are lots of tools that can assess it. So there's a Jeffersonian empathy scale and different instruments that you can use. There are also different frameworks for teaching empathy and teaching the demonstration. Again, I guess I'm trying to differentiate between empathy and the demonstration of empathy, or the way we communicate in order to show that, responding to patients and responding to emotion. So I've, with, again, some more colleagues from each, have just submitted a paper which they've got this beautiful empathy curriculum, a longitudinal empathy curriculum in their medical school in Leicester in the UK. And one of the things that they're bringing in there is this structure called BATHE, which is about encouraging students to ask a series of questions about the patient's sort of background, how the particular concern is affecting them, what's troubling them about it, how they're handling it or coping with it. And then empathy is a response to that. And so that's a really nice sort of structured way. Again, that can be translated into a rubric to say, oh, did they do these things, as opposed to did they feel? If we think about the definition of empathy, it's about, putting yourself in someone else's shoes and that sort of thing. And that's a tricky thing to actually observe. Compassion is often used as well, and often compassion is seen as empathy with an action. And so I think that can be an easier thing to kind of measure, which is the action. So what did you say to demonstrate that you've heard or understood a particular patient, understood their concerns, and those sorts of things. So rather than empathy as a measurement, I would say we can identify whether students respond to cues, whether they make appropriate statements and not just cliched ones, like "I'm sorry to hear that." Sometimes empathy can be in silence, in like allowing space and time for a person to just consider. But also it's about asking the questions which show that you care and understand what might be important to a person. So that was a really long way of answering, but I feel like it's not a straightforward concept to actually, to measure.
Thank you so much, Connor. Wow, this was rich and intense. Just as we hoped for. I just want to thank you so much. I just want to give it a try and summarize, and also share about our next events. So for me, just a couple of highlights of this hour and a half of Connor's story of multiple years of teaching and assessment. Connor started with how medical communication affects health outcomes, and gave us some ideas and clues where to look for data supporting the argument that how doctors or medical personnel communicate can have a huge impact on the health outcomes and different sides of them. The second point about what to teach for me was about moving from taking to sharing, like from history taking to story sharing, as a different framework of thinking about this process in a less transactional way and a more personal way. I think you use these words to describe it. The third point was about how to teach. And interestingly enough, I think our earlier speakers talked a lot about the importance of the experiential learning and various aspects of it. I think you did as well, but the main focus in your speech was really about feedback and how we can do both, how we can build really quality feedback into experiential learning, not just more role plays and discussions, but actual like very clear feedback and well structured. The fourth point is on assessment and how you emphasize that it's not like a one-time exercise, and how it should be done consistently throughout the program as a data collection, like showing the mosaic of different sites and different skills, not just like a one-time assessment. And I think the last point that I was particularly touched by is how you emphasize the need to integrate the feeling side, the patient perspective into the assessment. Thank you so much. I think these have been very precious points, and really they kind of add well to the picture of how to teach communication that we are painting together with you and our colleagues at EACH, and also from the Ukrainian medical schools. And I just want to say to our listeners that we will take a summer break and we will be back with this series in the fall. So we are planning to do a couple of discussions, and I can already tell you what the topics will be. We are going to do one live air with students. So we invited medical students to talk about how they learn communication and how they see what is their perspective to help us learn what they need. And then the 3 sessions that are already confirmed and the dates as well is a session with Peter Pipe from Belgium on interprofessional communication and how it's taught. Connor mentioned it a bit, and I think Peter co-authored one of the articles with Connor. So Peter will come to talk about how it's organized and how they changing curriculum to allow it. Then you have Remember Orit from May. She will also come back with a session on reflective practice in teaching. And then we are going to also have a session with Claudia Kisling, who is also a co-author of the article Connor mentioned on curriculum development and how to integrate it like a bigger picture of curriculum development. So thank you so much for your attention, and we will see you in September. And have a good rest and a good holiday, and please come back and stay with us. We are really looking forward to learning together with you.
Thanks, everyone.
Thank you. Very interesting and useful for us. Thank you.
Thank you so
Дякую.
much. Great.
Дякую.
Thank
Дякую
you.
за вашу активність і за ваші питання. Про чек-ліст і зразок чек-ліста
so much.
Thank you for
спитаємо,
being
може,
active. Thank you for your
відправимо
questions.
якщо
And
буде. Я
suppose there are
бачила
any
це.
further questions, we will
Ми
try
це все
to
збираємо
answer
і
in
будемо
writing.
теж
We are
ділитися
collecting all the
нотатками з
questions
вами.
and we will try to also share our notes with
Уточнимо,
you.
чи можемо надіслати
And we will
презентацію
clarify
передбачити,
whether the
зареєструвався
presentation can
попередньо.
also be shared with the registered
Дякую
participants.
за те, що ви знаходите
Thank
для
you.
цього
Thank you for
часу
being with
і
us. Thank you for
сподіваюся
finding some
побачити
time for
ще
such things. And let's hope that
в інших форматах.
we will see
Юлія,
each
запис
other
буде
later.
доступний
Julia is
пізніше,
asking whether the
запис
recording
буде
will be
на
there.
YouTube. У
Yes,
нас є
it will
окремий
be
канал
there. It will be on
зареєстровано
YouTube. We
всіх
have a
цих
separate
подій,
YouTube
ви можете
channel with all
там
those
шукати те, що
events.
пропустили
So
на
there you
каналі.
can be looking for what you have
Thank you
missed
so much.
by some accident.
That was great. Thank you. Thank you.
Mhm.